So I think we'll move on to the next session. This is actually, the most exciting one, which is a three-way debate, which is who should perform the left atrial appendage occlusion or exclusion, right? I mean, this is kind of, the surgeons think that they own the left atrial appendage, and then the interventionists came along and they think they own the appendage, and then the EPs came along, and we say we live in the left atrial appendage. We own it. So I'm going to invite all the three debaters on to the forum. That's going to be Dr. Holmes, Dr. Mack, and Dr. Horton. So what was the order in which who's going to go first? 1 second. Dr. Mack. Okay. So I have the extreme pleasure of introducing Dr. Michael Mack, who has done a lot of pioneering work in this area. So I'm looking forward to a great debate. Please.
Well, thank you, DJ. David and I have debated each other many times, and we've actually switched talks, sight unseen. So we're just debating, should he give my talk or should I give his talk, or should I give my own talk here? Take a vote. Yeah, what's the vote? All right. So it's a pleasure to be able to debate David again and Rodney. Unfortunately, I have no conflicts to disclose. So this is David's slide, and I think it illustrates well that when we are subspecialists and treating the same diseases, we oftentimes get in a tug-of-war with the patient in the middle. And now we have three people tugging at this patient. And to me, this is an entity that, rather than debating who should be doing it, is just crying for a heart team approach. Because, again, this is David's slide, is what happens when you don't work together is you end up with an unintended consequence. So this is Steve Jobs' biography. And there's an interesting anecdote in it when he was being treated at Stanford for his cancer. I realized that I was facing the type of problem with my oncology care that I never permitted at Apple. My treatment was fragmented rather than integrated. Nobody seemed to be in charge of figuring out how nutrition was related to pain care and oncology. I was being treated by oncologists, pain specialists, nutritionists, hepatologists, hematologists, and not being coordinated in a cohesive way. So he convened the team of various Stanford specialists at his house to coordinate his treatment. Now, can you imagine being summoned to that meeting? I'll bet you showed up, and I'll bet you didn't say a word, and I'll bet the team was together after that coordinating care. But it is a lesson that how somebody that's not in the healthcare field views what we do. So the collaboration between David and myself actually started about 2004 in the Syntax Trial Steering Committee, and we spent many hotel rooms, boy, that was a Freudian slip, many basement rooms in hotels together.
It's not what you think. It's not what you think.
So it was moving on in the early days of transcatheter valves. Fred Moore and myself, a surgeon in Leipzig, when we were doing the first transapical case. This is where Goethe wrote Faust, and this is Mephistopheles. And we made a deal with the devil, and this is Alain Cribier, a cardiologist who did the first transcatheter valve in the world, that helped us out. And this is the partner trial of a collaboration between 4 surgeons and cardiologists as a heart team figuring this out. And this is our heart team in Dallas doing interventional transcatheter valves of 2 specialties working together. And this is the German Societies of Cardiology and Cardiac Surgery collaborating together, ein Herz, ein Team, one heart, one team. So there have been a number of publications that have happened recently. So this is 3 publications that have been published simultaneously in the Annals of Thoracic Surgery, in the European Journal of Cardiothoracic Surgery and in the European Heart Journal, discussing Venn diagrams in cardiovascular disease, the heart team concept, with David being the primary author. And I think that this is very applicable to this field. And the whole concept is that rather than working in silos, that if we, like a Venn diagram, cross over, we have very many commonalities that we can work together and make a patient-centric approach rather than a physician-centric approach. Just published last week is the rationale for a heart team of decision-making for patients with stable, complex coronary artery disease. And you can see here, I mean, if there ever was strange bedfellows together in all this, there's interventional cardiologists, there's surgeons, there's Sanjay Kaul, who is the ultimate non-interventionalist, non-surgeon, as a co-author on this. And it is very worthwhile reading. It is available free from the European Heart Journal. But it outlines all the reasons why we do not work together and all the political issues that happen if we have to address if we are going to work together. And again, it's a Venn diagram in which the patient is at the center and an interventional cardiologist, cardiac surgeon, and clinical cardiologist all work together. So I would like to go through, so I'm a surgeon that does an interventional procedure, the MitraClip procedure, and kind of how I learned to do this. So I had a background of TAVR cases and TEVAR, and I watched 2 MitraClip cases. I went through a bench trop simulator and went to a transeptal course. This is my background skills in the cath lab in 1999, and who taught me in this transeptal course but David Holmes? He taught me how to do a transeptal. So what did I do next? Well, I came back home and I scrubbed on 5 AF cases with 2 transeptals per case and learned how to do transeptals in 2 weeks from my electrophysiologist. And then I got proctored by an interventional cardiologist, Saibal Kar, on how to do these procedures, and answered the question, how many cardiologists does it take to teach a surgeon how to do a MitraClip case? 3. But all this is a point of, I think we, rather than debating who should be doing this, we need to be moving is how do we do this together? So the traditional way that we're aligned in cardiology, cardiac surgery, and electrophysiology is by having these traditional specialties of non-interventional to interventional, pediatric cardiology, cardiac surgery, pediatric cardiac surgery, radiology, and electrophysiology. And I think we need to reorganize the service lines, and this is what we're doing. We're having a coronary team made up of a primary cardiologist, an interventionalist, a surgeon, and the emergency services for treatment of acute MIs, a mitral team, an aortic valve team, a congenital team, an aortic team, a heart failure team, and an arrhythmia team made up of a primary cardiologist, an electrophysiologist, and surgery. And this is how we're organized in the Baylor healthcare system now. We have a council that runs the whole system, 6 surgery programs and 17 cath labs. And it's a triumvirate that runs this from myself, an interventional cardiologist, David Brown, and Kevin Whelan, an electrophysiologist. And so we are in the initial stages of redesigning the whole hospital system as a service line approach, as I just mentioned. So as I look at this space, the management of atrial fibrillation and left atrial appendage is just something that's crying for a heart team approach to it. If we look at this this disease state, we can look at all the treatment options that are available for it, from catheter ablation to drugs, to ablation with pacemakers, to surgical maze procedures and pulmonary vein isolation, to hybrid approaches, to isolated left atrial appendage exclusion, and the whole field of anticoagulation. As I also looked at this paper from that looked at the looked at the anatomy of the left atrial appendage. We now have terms such as cacti, windsocks, and what's the third? Oh, chicken wing. Chicken wing. Now, it seems to me that we should be able to get sophisticated enough through a heart team approach of figuring out that probably all these are not best treated the same. There's some of these that are going to lend themselves to devices, some of these that are not going to be able to be done well surgery, but it seems to me that this is just an example of how working together we can just not treat the atrial appendage as one entity, but figure out who's going to be better by one approach than the other. So I would propose this heart team made up of an electrophysiologist, an imaging specialist that can get all of us CT scans on the left atrial appendage like you just saw in the previous slides, interventional cardiologists, CV surgeons, general cardiologists, and primary care physicians who are, I learned a new term this morning from Richard Whitlock, a thrombologist that manages the anticoagulation scheme, and then all this headed by a service line manager who frequently is a nurse practitioner that can help put all this together. So I would propose that this is the primary team that should be managing the left atrial appendage and atrial fibrillation as a service line in your institution. So David and I have had a great collaboration over the years. We worked very closely together on a lot of these concepts. And Dr. Horton, we would like to invite you into our club. Thank you.
I think Dr. Holmes is going to go next.